Hi everybody, and welcome to tonight's webinar. My name is Jared Hayes and I'm the Secretary of the Health Services Union in Queensland, New South Wales and the ACT. We've got some very special people with us tonight to have a discussion with you in relation to vaccination. We've been very concerned as a union for some time throughout this pandemic about safety and about people being vaccinated and how we look after each other. Clearly, we're at the point now where there's a range of vaccines out there. We're also seeing over the past 4 to 5 months that some people have had a hesitancy developed because of information that has been put out. That one is just not consistent. Other information has been put out that is just totally wrong. And then people have been worried. But if we put things in perspective, we see that these vaccines all work well. And many tablets and many medications we take every day don't have the risks associated. So it's really important to put things in perspective. Think about the tablets you would take every day and then think about the risks with those tablets and the risks with other things. Then I think we'll bring that into some form of perspective. But it is really important that we can talk, we can have a discussion, and we can actually move forward, because the only way, as everybody is saying, that we can move forward as a people and a country is that we look after each other, and looking after each other makes sure that we're all vaccinated and we can protect each other. So I'd like to welcome everybody tonight, and I'll hand over to Dr. Anthony Llewellyn, who will be chairing tonight, and the other excellent clinicians who are with him, who will be able to go through all your concerns. Thanks very much.
Thanks very much, Jared, and welcome everyone. I see we've already got 430 people odd chiming in, so we're probably going to hit the capacity for this meeting, which is great. So I'll shortly introduce our panelists and talk you through the process, but I just wanted to firstly say congratulations to the HSU for putting on this webinar. Thanks in particular to Jared and Lynn and the team for showing leadership. This is an issue that I've raised within my discussions about what's happening from the labour movement perspective in terms of encouraging workers to adopt vaccines and get vaccinated. So it's great that we're doing this tonight. I'd also like to acknowledge that we are meeting on I would assume a whole range of traditional Aboriginal lands and Torres Strait Islander lands tonight, and pay my respects to elders past, present, emerging, and any Indigenous perspectives from participants tonight as well. So what we're going to do tonight is we've fielded a whole lot of questions from the membership, and we actually got over 140 questions about various issues around vaccination and COVID. And we've sort of distilled them into a manageable number, and we're going to put them out to the panel so we can get you some answers to those questions. Some members have put in some very specific questions, so if your question isn't answered tonight, please be reassured that you'll get an answer to that question if it's a more specialized question. So I want to introduce the panel members. Just initially me, some people won't know me. So I'm Anthony, I'm a consultant psychiatrist. I work in Newcastle now as a management consultant coach. I've been a long-term member of the labour movement in Australia, and was a past HSU councillor for many years. Joining us tonight, in no particular order, just in my speaking notes, we've got Dr. Lee Fong, who's a Newcastle GP working in Adamstown. Hi, Lee. He's got probably the best background tonight. Lee has a particular interest in COVID-19 related issues. He's providing medical support for the H&E District Vaccination Hub, and is a senior clinical editor for the H&E Central Coast Healthpathways Clinical Guidelines. Also involved with Hunter Primary Care as an expert group member for the Therapeutic Guidelines group. We've also got Patrick Cashman, who Patrick's a public health nurse who specialises in immunisation. He set up and managed Vax Tracker, which is a program that provides COVID vaccination safety to the Therapeutic Goods Administration. So he's the guy who educates doctors about vaccinations. So I'm looking forward to being educated. And most importantly, he is a union member. We have Jamila Gejestani. Jamila is a senior industrial and work health and safety lawyer with over 8 years of experience in representing and advocating for union members across a variety of industries. And Jamila's here particularly to take the industrial questions. So thank you for that, Jamila. We have Tess. Tess Loxley is a paramedic working in Metro Sydney. So you'll be doing it hard right now. She's been on the front line of the pandemic in Sydney, responding to and transporting COVID patients across the hotspot LGAs. She's a passionate delegate with an interest in women's health and rights. Our international guest, Dr. Pradeep Rajagopalan. Pradeep is a general physician and respiratory specialist. He's been working in the UK for the last couple of years and has had first-hand experience dealing with COVID-19 in the UK. Very excited he agreed to join us tonight. I think he can provide a kind of different perspective on how bad COVID can get. And he's also seen to join us in Queensland at a job at the Townsville Hospital as a respiratory physician. And then finally, but certainly no least, Dr. Scott Winch. Scott is a Gunnegoda and Wiradjuri man. He is World Vision Australia's Senior First Nations Policy Advisor with training and expertise in epidemiology and public health, and an avid surfer. So I think I've covered everyone there. Oof. All right, so thank you everyone. So what I'm going to do is just go through these questions and invite some inputs. I'm trying to keep the time. We're aiming for no more than an hour tonight. But our first question that we've got here tonight is, what really happens when you get COVID? Don't most people get the flu and get over it? Can't my immune system cope with this illness? So this might be a good question to put to Dr. Rajagopalan. What's happened in the UK when people develop COVID over there, Pradeep?
Just unmuting myself. Thank you very much for this opportunity. Yes, COVID-19, when it first started in UK, when we started to get patients, because I'm generally a hospitalist and I work in NHS hospitals, and I've been doing since the first wave started, when the first cases actually started to arrive. And my background is I was actually running a ward full of COVID patients. So I actually look after them and also look after patients who require advanced respiratory support. So just to give you a perspective, so COVID and flu, flu is actually caused by this influenza virus, and as we all know, and the incubation period, what we call as the time, difference of what people can be infectious, varies between 3 to 5 days. The difference with COVID is it's almost similar in the presentation, but the late manifestations we see after 14 days of having the COVID is something which we don't see with the flu. So to start off with, and what I mean by late complications is people actually go on to what we call as acute respiratory distress syndrome, which means that their lungs are actually filled with fluid, and to the point that they actually require immediate respiratory support to actually live. So that can actually happen and very quickly in COVID patients. The initial first wave we saw, we had quite a lot of senior citizens and people actually getting that quite easily. And the masks, when we had the masks were actually introduced, the protection and the public health protection was actually introduced, and when we all started to actually do the quarantine and lockdown, by the time itself, within 2 weeks, 3 weeks, we actually saw an increasing number of cases. And the main difference between flu and thing is the mortality we see. Mortality, I meant, people dying of COVID. It varies, according to the new statistics which has come through. It is actually around 3 to 4%, which means 3 to 4 out of 100 who get COVID can actually die. But if you actually elaborate that to a hospital setting, the mortality actually even goes up higher, especially depending upon their underlying age, and also the comorbidities they have. For example, what I mean by comorbidities is if they have heart problems, if they have got underlying heart disease and diabetes, and various other immunosuppressive conditions, and etc., etc. And when you take that in a hospital population who are actually hospitalized, these comorbidities are very high compared to the general population. So at some point of time in the hospital, we had up to 17% mortality. which is far, far higher than what we expect with the flu. And that is actually a huge difference between what COVID and flu, how it actually manifests. For example, the mortality from flu, if you look at the statistics from Australia and also from UK, it's actually borders to around 0.1%. And most importantly, flu can actually, we have flu vaccines, and we actually have vaccines which change every year depending upon the strain of the flu virus. And because the flu virus changes its antigenicity, and I'm not a vaccine expert, but I'm sure the vaccine expert is going to actually talk about that. But I'm just saying, that actually is probably helped reduce the mortality to 0.1%. Otherwise, we might actually experience flu to that level as well. But this is it's a novel coronavirus. That's not how it actually is called. And the manifestations which we saw literally actually can from head to toe. So for example, people can have COVID toes, which is actually one of the manifestations which we came to know by June, July, that these are other manifestations. We initially thought cough and fever, high temperature were actually the predominant symptoms. And then we added on loss of smell and loss of taste as one of the other symptoms. And these are all extremely unique to this virus. And the flu virus doesn't actually cause any of these. I actually know, apart from occasional atypical features. But we also saw people who had extreme amount of clots in their lungs, and it was actually we call it's a double jeopardy for the lungs, because the blood vessels, which part of the lungs and which have the circulation between the heart and the lungs, they get the clots. So you actually get lack of blood supply. The lungs get filled rapidly with fluid, and it can't breathe. So it can't breathe and won't breathe. And so it's a double jeopardy, which you don't get with the flu. Influenza, and you're not seeing that. Yeah. And so it is most likely when we have to ventilate these patients in the intensive care, it was actually an enormous difficulty. Initially, we had to use very high pressures. And when they go into ITU, putting them on the intubation and ventilation, they are on it for at least 2 weeks. We don't see that with flu. So, if you actually start to list the differences, it is so many at so many levels, and in COVID and flu, which can actually make COVID appear 1,000 times sinister than flu. And hence, actually, we that I can vouch for, because I've actually looked after COVID patients, and we had third wave now in UK. The first wave was, the second wave were actually we started, the first wave was actually peak of April, and the second wave was actually somewhere in November, December, during the winter time. And that's when the vaccines got approved in December, with the Pfizer vaccine as well as the AstraZeneca. So once that actually comes through, the third wave which you are seeing now, I'm just giving you we had a mortality, a daily death rate of 1,000 in UK. And the same with Italy. You might have heard from Italy and UK. So, we are talking about 1,000 people per day dying. And that is actually aggregated. And whereas now, after the vaccines have been introduced, and UK, I have to say, have actually done well from that aspect. I'm not going to comment on the COVID quarantine aspect, but I'm actually saying about the aspect of vaccinating people. We actually had tremendous uptake. And this actually has shown that people have now opened up, and to sometimes to our peril, but at the same time, the death rate you actually see, we're actually talking about 24 to 50 per day compared to thousands in the first and second wave. That's actually a remarkable difference by any means, really. And despite the lockdown measures are not actually nowhere near what Australia has or New Zealand has done. So, it shows two things. One is the severity of COVID. And, we talk about the variants, the new Delta variant. We are still very, very, very concerned about that. But at the same time, with the vaccines, with people having double vaccines, and it's literally showed a difference to our admission rate. And the last 1 year, we have actually been spending my time mostly on COVID patients. With other patients, we are actually talking about other COPD patients, because that's our other respiratory patients and non-medical patients. We couldn't see many of them getting admitted, strangely, because people were actually in lockdown and people were having things. And I haven't seen a single case of flu during that time. And that's actually because the masking practices were actually very good, and the lockdown practices, and people who are what we classified as vulnerable, and also being shielded, and that actually worked well in the favor. So, the masking practices, again, that has actually helped a lot during that time. But, COVID overtook,
thanks,
for
Pradeep.
example,
sorry, I just want to make sure everyone gets a bit of time here, but I think that gives us quite a bit of perspective. So it's 1,000 deaths a day compared to 1,000 cases a day here in New South Wales. It's just a whole different manifestation, really, isn't it?
Sorry, Anthony. Still we have 26,000 positive cases. I'm not actually discounting, but I'm saying, people getting hospitalized and going to ITU and dying, or those kind of mortality is significantly gone down after the vaccination drive has increased.
Absolutely, great. So Tess, tell us about the sort of patients you've been seeing with COVID, because I think people are saying, well, if I'm fit and healthy, I'm not going to get it. Is that true?
No, sadly it's not. I'm going to fit and healthy people who have tested positive, and I am going to 2-month-old babies that are testing positive, who have been born healthy, who all of their tests have been fine. I'm going to 14 and 15-year-olds who, well, before lockdown, were going to school and doing PE and doing everything. I'm going to 30-year-olds who have been going to work, and I've been going to elderly who, despite being elderly, they were still living independent lives. They were doing everything they would usually do, and they're all getting COVID. To different extremes, yes. Some people do have minor symptoms. A lot of them, though, by the time they call us, have deteriorated and have more severe symptoms. But I think one of the most worrying thing is all of them, no matter how physically unwell they are absolutely petrified when they call us. It's a really scary virus to have. And unfortunately, we can't provide the answers. We don't know whether people are just going to have a sore throat or whether people are going to end up on a ventilator. And I think that's the hardest thing as a paramedic, is when people are looking at you with so much fear in their eyes as to what's going to happen to me. At the moment, unfortunately, I don't have the answers for those people.
Yeah, that's really terrifying. So one of the questions people have is, normally it takes us, Pradeep said, we've had the flu vaccine around for years, we change it every year. So normally it takes a long time to develop a vaccine for a bug. And yet suddenly we've got vaccines within 12 months or something like that, which is, amazingly quick. And so the concern is that, are we kind of still in experimental territory? Lee, might throw this to you initially to answer. Are these vaccines, are they experimental or are they free vaccines?
Oh, they're very much genuine vaccines. And I think just to return to what Pradeep said for a moment, the difference in the third wave that we're seeing in terms of hospitalisations and deaths in the UK speak very loudly. I think in terms of the efficacy, do they work? Absolutely. Cutting down 1,000 deaths a day down to 25 or 50, what a huge difference. It's like 20, 40 times less, which is, just remarkable, really. So are they experimental? No. Well, I think there's been so many given worldwide now, just massive numbers. So I think in the UK, probably, Pradeep, correct me, I think by the time you add up Pfizer, Moderna and AstraZeneca, we're looking at 80, 90 million, something like that, in that sort of order. Yep. In the US, where they focused on the mRNA vaccines with Pfizer and Moderna. I think at least 350 million, something like that. So really, really big numbers. And I wouldn't call them experimental at that stage. They've just been given on a huge scale. In terms of the question about, well, was it developed too fast? Well, there's a few reasons why they've been faster to develop. One is that, traditionally vaccines, they've used weakened versions of a virus or bits and pieces of it, and they've had to grow them in eggs or cells, and it was a prolonged manufacturing process. Whereas with some of these newer vaccine technologies, you don't have to go through that stuff. It's a shortcut process where instead of growing things in an egg, we stimulate the body to produce the material that then gets an immune response out of the body. So that's something that happens, and it's really shortened the process. Also, there's been bucket loads of money thrown at this, like just tremendous loads of money thrown at it. And they've compressed not so much the testing phase, but I mean, they've taken the manufacturing process and kicked it off even before the trials were all the way complete. And so did they take a risk on that? Absolutely. It meant that they could have ended up with millions and millions of vaccine that they then couldn't use. But that was the Operation Warp Speed? That was part of what they did. They took a punt and were willing to throw away a huge number of doses if it didn't work out. So these are all things that compress the time frame. Does that sort of answer that?
Yeah, no, thanks, Lee. I'm wondering, Patrick, do you have anything to comment on that particular question?
Yeah, thanks, Anthony. I think the science has been done all correctly and in the right time frame and very, very carefully, and that hasn't been rushed. What's been sped up, as Lee's nicely pointed out, is the administration side and the approval. So normally vaccines are a terrible investment because your vaccine's really expensive to make. You give someone once or twice and then they never need another product again. So if you're trying to sell products, vaccines are a terrible investment. But as Lee pointed out, there's lots of money's gone into this. So most of the vaccine development time is attracting funding, and then you make a few vaccines and then you've got to attract funding again and get more approvals and go on to the next stage. And it takes step after step after step, and it takes years and years and years. This time it's all been done in parallel instead of one after the other. And that's what's been sped up, is the administration and the approvals, not the science. The science is absolutely fantastic, and billions of people have already had these vaccines. They're not experimental and they work really well.
And Scott, I'd like to bring you in here. Why do we need so many people to get this vaccine? Where it's often quoted that we need at least 80% of the population vaccinated. In some countries, people have just had COVID and there's this concept of herd immunity. Why are we pushing so hard to get as many people vaccinated as possible?
Yeah, so it's fundamentally herd immunity, but it's also, I guess, the impact on the health system as well. So to have, like Pradeep's already explained, the vaccines has really impacted on the amount of people with acute disease. So that's going to be reduced. The hospital system will be able to cope much better with more people vaccinated. So it's, I guess, initially in Australia, we're about maintaining small case numbers or suppressing it as much as possible. Now it's probably likely this is going to be circulating for good. It's now about suppressing the acuity of disease. So yeah, vaccination rates are extremely important.
And are there certain vulnerable populations that we need to be aware of? And is it possible as a fit and healthy person, by having a vaccine, that you're helping out other people?
Yeah, absolutely. And obviously, as an Aboriginal man, my community is highly vulnerable. We've got higher rates of comorbidities that occurs at a much younger age as well. So extremely vulnerable. We've got higher household numbers, more contacts in community. So all these reasons for transmission of diseases are much higher in Aboriginal communities where it can be spread much more easily. So it's extremely important that we're protecting our community through vaccination, through social distancing, and all public health measures.
Okay, thanks for that. So some of the concerns are about the long-term side effects of having the vaccine. People have heard about clots and heart problems and people dying from vaccinations. Might come back to maybe Patrick. You want to fill this question first? Like, what's the risk of having a vaccine versus, what's out there at the moment with COVID?
Yeah, thanks, Anthony. So with any medical decision, if you're going to have an operation or anything we decide, it's a risk-benefit analysis. And the risk-benefit for these vaccines is definitely in the benefit. The disease is terrible. If you're come in contact with the virus, you're going to get sick. Tess has pointed out that even young, healthy people get sick. Now, the risks with the vaccine are very, very small. So if you had the MCG full of 100,000 people and you vaccinated all those people with the AstraZeneca vaccine, depending on your age group, about 2 or 3 people might get a blood clot. And it's not your regular blood clot. So no one wants a blood clot. When we used to do long haul flights, we'd walk around to make sure we didn't get a blood clot. We've given up cigarettes because we don't want blood clots. We do all the right things, look after ourselves so we don't get blood clots. But the way the AstraZeneca vaccine, when the very few cases are causes a blood clot, is a completely different mechanism. It's what's called an immune response. So the platelets get a bit sticky because of the immune response. So if you've got regular risk factors for blood clots, they're not placing you at risk for the blood clots from AstraZeneca. And a few months ago, when these blood clots were new from the AstraZeneca, they caught us by surprise and a few people did die, and that's public information up on the TGA website. But now we're much better at diagnosing it early. People are much better at coming in early, and we're not seeing people die from that anymore. Now, it's terrible to have a therapy and then end up with a bad effect from it. But the numbers are very, very few. Whereas if we can get everyone immunised, even with the AstraZeneca vaccine, it's going to make a huge difference to the whole community if we all pull together. And especially if you're a healthcare worker, it's really important that you protect yourself.
Yeah, I forget what the rates are. Maybe Lee might have, but what's the rate of just getting a blood clot from being on a plane or something like that in comparison to this AstraZeneca vaccine?
Oh, that's a good question. To be honest, I don't have that figure in my head. Patrick, have you got that?
No, not on the top of my head, but it's much more common. It's like 1 in 1,000. Like it's much, much more common. So there's lots of other risks of blood clots, but those risks don't come into play. So if you're over 60, you can go get your AstraZeneca vaccine, and if you've got other risks for blood clots, the AstraZeneca is not going to increase them.
And that's a really important point. I think a lot of people get concerned about having had a history of I've had a clot in my leg, or I've had heart problems or something else, or maybe even a stroke, and they've been worried about that. That might mean that puts them into a higher risk category if they take the AstraZeneca vaccine. But look, that's absolutely not the case. And like from a personal perspective, my mum's over 80 and she had a really bad stroke at the end of last year, had a clot stuck in her head, and she almost was looking like she might not pull through. She was really fortunate they were able to pull the clot out, and she was scared about getting the AstraZeneca vaccine. Actually took a lot of convincing from me to say, hey, it's actually a completely different mechanism. You're not at increased risk because you've had this stroke. And you know what? You're at an age group where you particularly need to be protected. So took a lot of convincing, but she's just had her second dose, and now she's telling all her friends to go and get it. So it's important to, as Patrick pointed out, it's a different sort of clotting.
And are there any other risks that you talk to people about when they come in for their vaccine leave that we need to be aware of?
Yeah, well, look, it's mostly, there's actually very, very few contraindications, like true contraindications to getting any of the vaccines that we have available for COVID, whether it's the AstraZeneca or the Pfizer. And pretty much all it comes down to is if you've had a really severe allergic reaction, like we call anaphylaxis, to your first dose, then you probably wouldn't have the second dose, but that's a really, really rare event. And another one would be if you have anaphylaxis to something that's in the vaccine. And there's a couple of different things in there. People might have heard of polyethylene glycol, PEG, or polysorbate 80 as being some components that are inside the vaccines. Again, super duper rare, really, really rare. There's a few, sorry, go on.
I was going to say, generally you just have a different vaccine if that's the case, so don't you?
Yeah, that's right. Yeah, we've got a couple to choose from. So that's usually not a problem. And look, we've vaccinated, I don't know, tens and tens of thousands of people up here in Newcastle at our vaccination hub. And I just haven't, it's just been nothing. Now, I've not actually seen a true anaphylaxis, like a real full-on anaphylaxis happen yet. It's just vanishingly rare.
Yeah, they won't make you, I've been through the experience of the hub, but at the John Hunter, and you sit there for 15 minutes and nothing happens.
So everyone's waiting for something to happen because everyone's a little bit nervous because it's, it's a little bit new and it's a little bit, you wonder.
Yeah,
but
we wouldn't do that with the flu vaccine. You just go bye and what about pregnancy? Because that's been one issue. There's been a lot of confusion around what to do. What's the advice on pregnancy, Lee and Scott? That's okay.
Look, from the pregnancy point of view, I mean, there wasn't a huge amount of evidence in the trials that were done. I think a lot of them specifically excluded people that were pregnant. But because we're talking into the hundreds of millions of doses that have been given now, there's been a bucket load that have ended up being given to people who were pregnant. Maybe sometimes they didn't know they were pregnant and they ended up getting the vaccine. And there's been no evidence of any problems. So there's been no evidence of any risk of, say, miscarriage or any risk of stillbirth or any risk of any like birth defects or anything like that. What we do know, though, is that if you're pregnant, you might be at increased risk of getting particularly unwell, especially if you get infected in your third trimester or you've got underlying medical problems. So the current advice is just really straightforward. It's like, if you're pregnant, get vaccinated.
And then any issues, Scott, in any specific groups, Indigenous groups, other cultures, backgrounds with the vaccine that you're aware of?
Well, I think there is a bit of perceived, risk within the community, and there's some hesitancy. I know that in our community there's lower vaccination rates as occurring in other minority communities. So I guess it's important that the right information's out there. I know our mob are big on Facebook, so you got to make sure you get the right sources of information, and that it's coming from proven and reputable sources rather than just following a friend's share or something like that. So there's definitely a lot of misinformation out there. So I think it's important, any First Nations people here on this webinar, it's also our role to kind of educate our communities and our families, and provide them with the right information, so that they're well informed, they understand the benefits of vaccination and how that can protect not only themselves, but their families and communities as well. It's extremely important that we get vaccinated. We've seen some communities where there's outbreaks occurring at the moment, and we've got such a big risk of it spreading through our communities at much higher rates, faster rates. So we've got to all play our part in protecting our families and our communities.
Absolutely. Tess, are you facing any misinformation on the front line?
Yeah, definitely. I think when we go and we ask, one of the questions we might ask when they're giving us their symptoms is, have you been vaccinated? And I'm finding more in that kind of 30 to 60-year-old kind of group, there's a lot of hesitancy. My older patients are really super excited to tell me that they got it. And, we've had both the jabs, how come I've got a headache today? Whereas it's that middle cohort that are quite worried. But I'm also finding that just through chatting, it's really easy to reassure them. Both my parents had the AstraZeneca. I'm anaphylactic to a few vaccines because of an egg allergy. And I explained that I've had the vaccine. It's a completely different to all other vaccines. I got a dead arm. It felt like my brother had punched me for 3 hours and I was able to go on. And just having that kind of a chat with people I don't know, they're stuck in the back of a car with me for half an hour. But by the end of it, I seem to have them convinced and they're pretty keen to sign up and get it.
Great. Now, a lot pretty. Sorry, was someone going to chime in?
Hi, Anthony. This is Jamila. I just wanted to add to the question around pregnancy. I just wanted to say that I'm 4 months pregnant at the moment. And as soon as the advice from ATAGI was that pregnant women can get the vaccine, I read the advice, and to me, the risk of getting COVID to myself and my unborn child significantly high, especially now in New South Wales, due to community transmission, than having any form of allergic reaction or side effects to me or the baby. And my husband and I had a lengthy conversation about this, and we made the decision that it was safer for me to get the vaccine. And I did. I got the vaccine. I have had both doses now. My second dose was 2 weeks ago. I fortunately had no side effects whatsoever, apart from a sore arm, perfectly fine. And on Monday, I did my 20-week ultrasound. The baby's perfectly fine, and I'm perfectly fine, and there's no issues.
Brilliant.
Anthony, it's
keep you there because
Patrick here. The COVID disease is unusual. You breathe it in, and a lot of respiratory diseases just stay in the lungs, but COVID gets into the blood, and the reports from overseas of people who've died of COVID, it just really clots up their whole system. And obviously the baby gets a lot of blood from mum. So anywhere where there's blood flow, COVID disease is a big problem. And I know people are worried about adverse events, but we look really hard. I've set up a system where we contact people after the vaccine, and we've contacted over 2.5 million Australians just in the last few months to see how they're going. And there's a whole system with Ausvac Safety and the TGA. There's a whole system of safety there. And we tell people, if you find a problem, we tell people. So it's all transparent. It's up on the TGA website. There's nothing hidden. There's nothing you have to worry about. If doctors and nurses find a problem with a product, they don't want to be giving it. They want to tell people about it. They want everyone to know about it. So there's a whole transparent system of vaccine safety there. Certainly nothing hidden.
And that in fact actually happened with the Queensland, University of Queensland vaccine. It was looking really good, and then it was throwing up some false positives, unfortunately. So they took it offline and said, no, we've got to look at another one. So that's good. Jamila, what I've got you there, we've got a couple of industrial questions. So I want to get through these because I think these are really important. I think everyone watching tonight is a worker. Or a partner of a worker possibly, but still invested. So first question, if I refuse to have a vaccine and my employer requires me to have one, can they terminate my employment?
If there is a public health order, which at the moment the government has published it, one today and one on Friday, then you will need to get the vaccine. Your employer can require you to get the vaccine because the public health order is law. If you have a medical exemption, then yes, your employer can try to redeploy you into a different role where you're not as exposed. But where a public health order exists, you have to get the vaccine because that is law. In the event that you choose not to get the vaccine and you don't have an exemption, but you're just choosing not to get the vaccine, then the employer has the right to terminate your employment because you're no longer meeting the inherent requirements of the role.
Okay, so that's pretty clear. There's no appealing to a court, going to the higher court. There's nothing in the Constitution that gets us out of it.
Nothing. The public health order is law, and we have to comply with that as a worker. If you're required to get the vaccine through a public health order, then you have to get the vaccine. And if you don't have, the only way not to get it is if you have a clear medical exemption. And if you don't have that medical exemption, then your employer can terminate your employment. Just to give everyone a bit of a background, on Friday, the public health order came for all authorised workers in the 12 LGAs of concern in New South Wales, that they must get the vaccine by the 30th of August, first dose only. And if they would not need to get the vaccine if their employer is doing their rapid antigen testing, which most employers aren't. So those workers would be required to get their first dose by the 30th of August. In the event that they don't, their employer has the right to refuse them work. For healthcare workers outside of the 12 areas of concern, they would need to get the first dose of the vaccine by the 30th of September. And for disability aged care workers outside of the 12 areas of concern, they would need to get their vaccine by the 17th of September, except if they're a contract maintenance worker or a student in aged care, then they can get the first dose by the 31st of October. And for disability workers, the rule applies if you're in the 12 area LGEAs of concern, you have to get your first dose by the 30th of August, or your employer has to do antigen rapid testing. And the government has now provided a number of vaccine links where authorised workers can go and book appointments. We've been notified that there are over 200,000 spots for workers, authorised workers, to go and book those appointments. So lots of available booking spots in New South Wales for the next couple of weeks, a couple of months, for people to get their first dose of vaccines.
So that's pretty clear. So the follow-on question is then, and we've heard that it's really highly unlikely that you are going to get a complication from this vaccine. But the next question is, if you are made to have a vaccine and something happens to you, will you be compensated? What's the law around that, Jamila?
So if an employer, if you are having to get the vaccine because it's a requirement of your role, and anything was to happen to you, whether it's an adverse reaction or anything more serious than that, then you are covered through workers' compensation. It will be treated as any other injury or illness that you may have got through work.
Great, thank you for that. And Pradeep, I presume in the NHS you've been required to have the vaccine. That's been made law, has it?
It's actually surprisingly not a law, but they are some trusts, NHS trusts, are actually making it mandatory for them to make sure that it is, that they should have both the vaccines, at least the healthcare workers, at least. That is actually very important, and I'm glad that you have a PHE order, but I think it's probably UK is actually probably not as vibrant in that aspect with regards to having a PHE law. But generally what I feel is the vaccine uptake has been actually generally good voluntarily. So I think it's probably the reason why they have actually not made it mandatory. But of course, in a healthcare setting, it makes much sense to actually have every healthcare worker who is working in a hospital or a GP practice or in any other healthcare circumstance should be actually vaccinated. And many trusts are actually insisting that. I have to say that it is not uniform, probably because because of the rights, human rights, and other things, and people can actually claim that. But I think generally, I feel the vaccine uptake has been voluntarily very good in UK, and there's quite a high percentage of people have been vaccinated. So that makes it probably the reason why the government has not gone that route.
Okay, and Pradeep, you mentioned earlier on in the piece that you're seeing lots of people with comorbidity complications with COVID, essentially. Like one of the concerns from our members is, if they have an underlying health issue, does that mean that they should get the vaccine even more? Maybe have a few more doses, and what should they do? What have you seen in your experience?
I think generally there are vulnerable groups and people we see with a high body mass index, diabetes, hypertension, and other things seem to, the first wave, we have seen more of them actually having COVID and affected, and the vulnerable groups. And I've actually seen in the second and the third wave, we don't see that much, especially with the people who are actually vaccinated. And if they especially had two vaccinations up to 12 weeks apart, and we do still see some people getting admitted despite having the vaccine, having the comorbidities, but it is actually they actually get discharged in 5 to 7 days, and that is actually a huge change from what I've seen in the first waves, where they end up in the beds requiring oxygen, high flow oxygens, requiring respiratory support invariably, and especially if they have the same comorbidities. So I'm actually, as Dr. Fong said, I've seen the difference between the first and the third wave. This is a huge, remarkable difference, even in people with comorbidities. And especially in people with comorbidities, I would actually say it's wiser and it is very important that they actually get vaccinated. And there has been, I think we are actually much more wiser now, retrospectively looking, because we had more studies which has actually come out. And I have to say, the last 1 year, the amount of information overload, I would actually say, with the amount of studies which are being done for COVID, with the vaccine efficacies and other things, it is amazing how much of work has actually been done. That's actually a positive side to COVID. The international scientific community has come together, and we're actually just, it's too hard sometimes to keep up. But there are actually extremely good quality studies about this vaccine's effect on these people with comorbidities. And most importantly, we see a disproportionate problems. For example, they call us Black and minority ethnic group in UK. Invariably had a huge impact because of the COVID, because they are disproportionately more affected. And I'm pretty sure it is actually going to be the same with any other group. And probably because it's the place where, how their working style and the comorbidities, we know that BMA group actually have more diabetes and more requiring kidney transplant. And then, there is a classic saying that people are not able to get the kidney transplants because there are not actually that many kidney donors. So there is lots of things, comorbidities which are attached to it, which actually makes the vulnerable groups even more vulnerable. And, I think we saw that in the healthcare workers as well. For example, 1,500 healthcare workers lost their lives because of COVID. It might be slightly an underestimate. 1,500 healthcare workers is actually a huge number. And, that's what we know. And, if you look at the majority of the people who had passed away, doctors and nurses and other healthcare workers, paramedics, and if you look at it, there is actually slightly disproportionate representation from BAME groups. And I think that is one thing which there are multiple factors they're still being studied into. And that's why I would actually say vaccinating. This has actually definitely changed the way these people are presenting, even with comorbidity. So back to your question, I would say definitely vulnerable people should actually get vaccinated even more, and they should be given the priority. And that's how UK was actually leading, because they actually first started with people above 80 getting vaccinated, and they started 60 and then 40. Now we are actually now in the age group of 18, 25. And I think once the approval comes, I'm pretty sure they will actually also start to vaccinate the little ones. So, I, as a clinician, I actually see that it is a remarkable difference how the vaccinations have helped in my perspective of seeing patients. And the severity of the disease is certainly actually much, much lower than what I've seen in the first and second waves.
Thank you, Pradeep. So we've actually gotten through all our questions on time, which is great. What I'm going to do shortly is go around the panel and just give everyone 30 seconds to just give a final comment or thought. Before I do that, though, if you are leaving or about to leave, there is a little exit survey we'd love you to complete on your exit. There's just a couple of questions which will help us to know whether this webinar is being helpful, basically. So yeah, I might go around the panel. I might start with Pat. Any final thoughts you wanted to put forward for tonight?
Yeah, so we take medications and we take them to improve our own health. Vaccines are quite unique because you actually take them for other people as well as yourself. So if I don't take my antihypertensives and I stroke out now, it's really not a problem to anyone else. Oh, it's a bit of an ethical issue. Maybe you've got to call Tessa's colleagues and go, pick me up. But it's not a problem for you. Whereas if I don't vaccinate and then I come in contact with you, then we're both in trouble. So you do it for yourself, and you do it for your colleagues, and you do it for your family and the whole community. So it's something we do for other people as well as ourselves.
Right. Jamila, final comment from you?
My final point would be there's a public health order in place now for healthcare workers, aged care workers, disability workers, and a number of other authorised workers. And it's really important that you do get that first dose of the vaccine. Otherwise, your employment could be in jeopardy, especially if you don't have a medical exemption. You won't meet the inherent requirements of your role. If you need access to the vaccine or help accessing links, we will be able to assist you with that. A newsletter has gone out to a number of our members, and further information will go out providing links to vaccine appointments that you can book.
Thanks, Jamila. Scott?
Yeah, so I guess my main point is that, you know, we're being protected at the moment through social isolation and infection control, but society will open up at some point, and our only protections then will be vaccinations, and particularly for vulnerable communities, we need to get in now and really make a big effort to vaccinate as many of our community and protect us when things open up fully.
Absolutely. Lee?
Yeah, I think, look, just to follow on from that thought about society opening up, I think we're at a point now where, you know, a bit of a catch cry is it might be in the next 6 months, the next 12 months, maybe in the next 2 years, everyone's in Australia is pretty much guaranteed one of two possible outcomes, which is you're either going to get vaccinated against COVID or you're going to get COVID. And when you look at those two options, you know, the worst possible risk in terms of the available vaccines is, yeah, is there a chance of dying? Well, yeah, it's potentially less than 1 in a million. When you look at the really worst possible side effects from the vaccines, what's the risk of dying if you get COVID? In Australia, it's at the moment, it's about 2 or 3 in 100. And so less than 1 in a million versus 2 or 3 in 100. I know which one I'd pick, and that's the one I've picked for myself and my family.
And we are a nation of gamblers, so it should be pretty obvious which one to go. Yes, absolutely, Lee. Pradeep, your final thought.
You know, I think couldn't have said better, like Dr. Fong. You know, I actually got vaccinated myself with AstraZeneca, and my whole family actually got vaccinated with AstraZeneca, and I'm actually still here. And you know, and I think it's very important. The more I see the effect of the vaccine, actually, the more it makes me think that people should actually be taking this vaccine, because that's the only way forward with regards to reducing the severity. And then, as someone rightly mentioned, we might have to live with this COVID at some, with having the COVID endemics. And seeing what Dr. Fong said, it's quite clear that if you're 3 to 4 out of 100 in UK can die when they actually have COVID in the first, second waves, 3 to 4 per 100. And, compared to that, when you actually have 1 in a million side effect with vaccines, and now we actually have millions and millions of vaccines being given, and people actually having a normal quality of life, and they're actually about to go about and have that freedom. I think that really, it makes me think that we should, everyone should actually get the vaccine if offered. And that, it makes obvious sense to me, and it should make obvious sense to anybody.
And thanks very much for joining us from halfway around the world as well. Fully appreciate it. I'm going to give Tess the final say from the front line, because I understand she's got a story she wants to tell. But before I do that, I just want to relate one thing I was talking about with a medical student that I'm working with today. There have been some silver linings to this situation. We were joking about how in the old days, if you were sick with a respiratory virus and on a medical team, if you didn't come in, you were letting the team down. These days, if you do come in, you're letting the team down, which is arguably a better situation. I do hope that actually stays out of all this COVID situation. But Tess, final comment from you from the front line.
Yeah, I don't have statistics or numbers. I just have jobs. And last week I went to a job. I went to a small unit in southwest Sydney that was on a high level of a building. There was a single mum with 2 children. One of the children was special needs, and he goes to a special needs daycare. And while at the daycare, one of the carers had COVID and has passed it on. He caught the virus and he also passed it on to his sister. The mum had had her first dose of vaccine a little over 2 weeks prior to them contracting the virus. So this family of 3 are living in a 2-bedroom unit upstairs in southwest Sydney. They can't go out. They can't go to the park. They can't go walking. They can't do anything. They're trapped. Yet in this tiny unit, every test that mum has had so far, and it had been roughly 16 days since the first child had been diagnosed, mum has continued to test negative. If she had tested positive, if she hadn't been vaccinated, there's a very good chance she would have been tested positive. I would have had to be calling police and social services to work out who could look after the 2 children if I had to transport mum. That small needle, and I go to a lot of people who call us with side effects from the vaccines, and mostly their fevers, their headaches, their lethargy. I give them Panadol, they either stay at home or they come to hospital and they're discharged 2 weeks later. That is so much worth it for that mum to continue to be able to look after her children.
Absolutely.
So I guess that's my experience, and I will tell anyone and everyone about that family because it's going to save lives.
Absolutely. Thanks, Tess. And thanks to all our panel members tonight. Thanks to Patrick, Lee, Pradeep, Jamila, Scott, and Tess. Thanks also to Jared and Lynn and the team, and particularly Lauren Hutchins and Chelsea Barker, who've been putting this together. Thanks to all you guys who have participated. I think we almost broke the 500 limit, which was very impressive. I've just been asked to let you know that this is not the last time that the HSU will be talking to the members about this issue and encouraging them to take up vaccination and trying to work through some of the fears and anxieties that you may have. And I know from my past history with this organisation, there's a lot of goodwill here, and you know, we're here to look after you, and we want to hear from you and your concerns. But I guess other than that, thank you everyone for attending, and good night. We wish you all well.